gives me a great pleasure and honor to announce the start of this webinar and a series of webinars that has come in collaboration with the Department of Obstetrics and Reproductive Medicine, Faculty of Medicine, Assiut University, and the Division of Reproductive Endocrinology and Infertility, British Columbia University, Vancouver, Canada. First, I'd like to thank Professor Bedaiwy and his team for this collaboration. Without them and without their effort and without their valuable lectures, this would not be possible to happen. In addition, I'd like to thank our team here in Assiut, Professor Abdel Alim, Professor Shaban, and Dr. Haroon. At last but not least, I'd like to thank IPSA Pharmaceuticals for their continuous support, and without their help, this webinars or this series of webinars will not be possible to happen. Today, we have a very distinguished speaker. I think he doesn't need any introduction. Most of you know him very well. This is Professor Bedaiwy. We are proud that Professor Bedaiwy has graduated from Assiut University, Egypt, in the year of 1992, and now he holds the post of professor and division head of the Reproductive Endocrinology and Infertility Department of Obstetrics, Faculty of Medicine, British Columbia University, Vancouver, and Canada. Dr. Bedaiwy is double board certified by the American Board of Obstetrics and the Reproductive Endocrinology and Infertility. He is also a fellow of the American College of Obstetrics and Gynecology and a fellow of the Royal College of Physicians and Surgeons of Canada. The CV of Dr. Bedaiwy is very long. If I'm going to speak about what he did and what he achieved, this will take the whole webinar. So I'm just going to give a few hints. Dr. Bedaiwy received his medical degree from Assiut, and he graduated and spent his residency in Obstetrics and Reproductive Endocrinology at Cleveland, Ohio, clinical fellowship at Cleveland, Ohio, clinical fellowship in minimal invasive surgery in Cleveland, Ohio, research fellow in reproductive biology also at Cleveland, Ohio, fellowship in reproductive sciences from the University of Toronto, Canada, and he got a PhD from the University of Maastricht, the Netherlands. Professor Bedaiwy is a very well-known figure, both nationally and internationally, and he published over 370 peer-reviewed papers, book, chapters, and videos. So I'm very proud that he is with us today, and we will start after giving his layout of this collaboration. Please, Professor Bedaiwy.
Thank you very much, Professor Al-Hussaini, for this introduction. It's a great honor and pleasure to be with you today live, and in collaboration with Assiut University, we are proud to present to you a series of webinars and seminars that are tackling different aspects of our specialty. The name that you see in front of you is actually crafted and selected by Professor Omar Shaban, whose role is very instrumental in the coordination and the initiation of this course. So what are the objectives and what are we trying to achieve by this course? I'd like to share with you some up-to-date knowledge and also evidence-based facts that can help you in your practice. And we also are trying to build on existing and ongoing educational activities in the field, particularly locally in Egypt by the Egyptian Fertility Sterility Society, the Egyptian Foundation of Reproductive Medicine and Embryology, and the Upper Egypt Assisted Reproductive Symposium, in addition to sharing with you actually what we see as a gap in the knowledge about core endocrinology, which should represent the foundation upon which all clinical decision making should be based. And we would like also to share a little bit of knowledge translation of some discoveries in the basic science fields that's related to the RAI field. Not forgetting that the majority of our audience are clinicians and practitioners and university professors who would like to get some clinical pearls and practice steps so they can help their patients and they help their community. You'll find a lot of that throughout the entire series of webinars. So we are targeting very much everybody. We're targeting medical students, we're targeting residents, fellows, assistant lecturers, masters and MD students, practitioners, university faculty, beginners and well-established, and also basic scientists. They will find something of relevance to them in this webinar series. As Professor Tarek mentioned, this is a collaborative effort between different institutions, started with Assiut University and with us here at the University of British Columbia, Vancouver, Canada, and friends and colleagues from the University Hospital of Cleveland and the Cleveland Clinic Foundation, both which are affiliated with the Lerner College of Medicine at Case Western Reserve University. So this webinar series will go into different rounds. So for the first round, which would last approximately 3 months, the faculty from the University of British Columbia, John Havelock, who's very well known in the field in Canada. Neve Talon is our fellowship director. Ryan Flanagan is a male infertility fellowship director. Tim Rose, a world authority in premature ovarian failure and menopause. From Cleveland Clinic in the first round, Dr. Tommaso Falconi, who is currently actually the chief of staff and the medical director of Cleveland Clinic branch in London, will be joining us as well. We have the whole team actually of the University Hospital of Cleveland at Ahuja Fertility Center kindly agreed to share their knowledge and expertise with us. Professor James Liu is the chairman of the department. Rebecca Flecht is my classmate, and she's currently the division director of reproductive endocrinology and infertility at the University Hospital of Cleveland and McDonald's Women's Hospital. Sam Masiano is a world-renowned biologist and placental endocrinologist. And Dr. Weinman and Dr. Findlay from the same center also will be joining. Confirmed so far is the first 4 lectures or first 4 webinars. The one after me would be March 7th with John, speaking about neuroendocrinology and mechanism of hormone action. What should the IVF practitioners know? And then I will be joining Dr. Falconi. Both of us will be talking about endometriosis and adenomyosis, mostly from the fertility and IVF perspective. And then we will end that first 4 series of lectures by Dr. Tim Rowe, who will be addressing the fertility and lifestyle needs of perimenopausal, menopausal women and patients with premature ovarian insufficiency. So why should you attend this webinar compared to others? What is new? What's different? So really, actually, it's crafted based on needs assessment to fill some of the educational gaps. And it's also flexible. So we are open to your suggestions if you want to change in the format or in the contents of the course. You can touch base with Professor Al-Hussaini with his team in Assiut or with me directly. And also the lectures can be made available based on the request from the Assiut University through their platform, as well as the platform provided by EBSA. And I think the contact person for that is Professor Mahmoud Abdelalim. We'll also provide reading material to those who are interested to read more about the different topics that we'll be covering, and that would be based on two famous core textbooks in reproductive endocrinology and infertility, Spiros, that the majority of you know, and Yan and Jaffe as well. We'll be up to date with the current guidelines and recommendations from the American Society of Reproductive Medicine and the European Society for Human Reproduction and Embryology, and up-to-date evidence from famous and high-impact journals like the New England and Lancet. So I want to spend a few minutes to acknowledge the contribution of people who worked hard behind the scenes in order to bring that together. I would like to start by thanking Assiut University administration and leadership for their visionary leadership, as well as for their support of this initiative and the support for our department. I also want to thank Dr. Ali Haroun, Assistant Professor of Obstetrics and Gynecology at Assiut University, for his efforts. Professor Mahmoud Abdelalim, who is Professor of OBGYN at Assiut University, and he's a current chair of the Ethics Committee in Assiut University School of Medicine. So he will keep us up to his high standards. I'd like also to thank Professor Omar Mamdouh Shaban, who is Professor of Obstetrics and Gynecology and head of the research grant office at the School of Medicine, and he's also the head of the International Relations Office. I have endless talks and communications with Omar to organize, and he has been a great help and great energy behind the scenes in order to put all of this together. So I really sincerely thank him for his vision and for his leadership as well. Well, this entire team is actually working with a great leader, and that is Professor Tarek Khalaf Al-Hussaini, who's the current department head of Obstetrics and Gynecology. I'm proud to say that he was my MD supervisor when I was in Egypt. He taught me when I was a medical student, and he continued to provide guidance and support throughout the entire journey. Professor Tarek is also enthusiastic about this initiative. He's putting his full effort and support behind it. So I sincerely thank him for what he has done so far. And again, as Professor Tarek mentioned, this initiative wouldn't have been possible without the endless support that we received from EBSA, Professor Dr. Rafiq Rami and Dr. Ishaq and Ms. Inji Hani and the Free Flight team in order to put the technology together to enable us to communicate from the most western part of the continent in Vancouver, Canada, to Assiut and to Egypt. So thank you to EBSA. Just want to remind you that the second lecture in this series will be very interesting one. I personally planning to attend the entire webinar, but the recent advances in neuroendocrinology and mechanism of hormone action that would be applicable to what we do in the fertility field, particularly in IVF, by John Havelock, who's an associate professor in our department. With that, I think I finished my introductory slides, and we're gonna get started. We kick in with the first lecture in this series. And just bear with me for a second to bring the next set of slides. Yeah, somebody can raise the hands to see if you can see my slides. Perfect. So today's topic is a relatively neglected topic in reproductive medicine. And that is about how can we effectively manage the first trimester. And I'll share with you that we probably should change that word shortly. How can we address the uncertainties that we see when we scan a woman who got pregnant, either naturally or following assisted conception? How can we address the viability issues, the visibility issues, as well as the location of the pregnancy? What is new in this field? And how can we take that knowledge in a way to help our patients? Here are my disclosures, nothing relevant to the title of this talk. And another disclosure that I have to preface this talk by saying that I am not a fetal medicine expert, but I have expertise and interest in recurrent pregnancy loss and recurrent implantation failure, as I'm one of the team members who run our provincial program for recurrent pregnancy loss. We also have a very highly sophisticated early pregnancy assessment clinic in our hospital. And early pregnancy, for those of you who don't know, is an integral part of reproductive endocrinology and infertility in North America. So we received training during fellowship, and we continue to use what we trained for throughout our entire practice. I also have some research interests in recurrent pregnancy loss and recurrent implantation failure. There will be some videos actually in this lecture. All of them are from my patients, and majority of the images that you will see are also from our center. And if there are some images that I'm quoting, I will refer to the source. So what am I trying to achieve today? I'm trying to share with you some evidence-based approaches to evaluate pregnancy in the first trimester, with a focus on pregnancy of uncertain viability, pregnancy of unknown location, early pregnancy demise or early embryonic demise, non-visualized and visualized pregnancy losses, each of which is a recognized clinical entity that has its own management algorithm. And I also would like to share with you and help you understand the potential for the 7 to 10 week scan that can be implemented and used towards early anatomy screen rather than waiting until 20 weeks gestation. We'll also share some of our first trimester protocols here at the British Columbia Women's Hospital in Vancouver with you as well. So let's revisit the concept of the first trimester. How did it start, and is it really accurate? So historically and traditionally, we have been taught that the first trimester are the first 12 weeks of pregnancy. And this is in reference to the time when the uterus moves from being a pelvic organ to being an abdominal organ. But it's an arbitrary time divider, because it does not reflect naturally occurring events, whether at the developmental level, clinical level, anatomical level, or even the loss rate. So what should we use instead? That is to talk about the way we think about the early pregnancy. I think we have to start using the embryonic period and the field period. And the reason behind that is, for most of you know, the embryonic period is a 5 weeks window between 35 days from the last menstrual period to 70 days from the last menstrual period, or the first day of the last menstrual period. And that represents 10 weeks, and that is an embryonic period, and during which organogenesis happen. That's why teratogens are quite important. At the end of that period, or during that period, the embryo is looking like the tadpole-like structure from the comparative embryology point of view. Beyond that point, from 70 days on, we're dealing with a fetus. So we cannot use the word fetus before 10 weeks gestation, because this is developmentally, anatomically, and clinically not accurate. And this is a period of growth and differentiation. So organogenesis is done. That's it. We're done with organogenesis at this stage. And that is when the fetus starts to take the human-like appearance. So then I'm going to revisit the title of my talk, and my focus will be, what is our clinical approach to the embryonic period rather than the first trimester? Because from 10 weeks on, we're talking about the fetus, which is a completely different clinical scenario. So why now? Because early pregnancy really has witnessed a significant major changes in the playing field over the past decade specifically. And that is because of the modern HCG assay technology, as well as the revolution of ultrasound technology, starting from the 2D to 3D and over 4D, and God knows how many Ds will come after that. So another disclosure, I'm not going to talk about any 3D issues in my lecture today, because it is not the first line assessment for early pregnancy. So let's start with the HCG. What is new? What should we know about HCG? We all know that it comes from the trophoblast, and it's detectable 8 days post-conception. Currently and erroneously, it's referred to as a beta HCG in reference to the beta subunit that distinguish it from other hormones that share the same alpha unit, subunit, like the TSH, FSH, and LH. And that goes back to a date when we have some limited assays that measured only the beta unit. The majority of the current assay that we use are measuring the intact HCG molecule and not only the beta HCG. That is the first thing we'd like to share. So how it all starts. We have an implantation that happens, and the villus from the placenta starts to invade the endometrium, which is no longer called endometrium during pregnancy. It's called decidua. If we look at the cellular component at the maternal side, you have the decidual epithelium and you have the decidual stroma. Decidual epithelium actually is the endometrium, and decidual stroma is the endometrial stroma. So on the other end, at the fetal end, we have three types of cell. We have the cytotrophoblast, which is responsible for the growth and differentiation of the early placenta. The syncytial, which takes care of the majority of the hormonal functions, particularly HCG and P4. And we have the extravillus trophoblast, which is not really connected to the main villus here, but it is responsible for the invasion of the placental villi into the maternal side. All three types of cell work in coordination to maintain the pregnancy. And that interface where the chorionic villi or the placental villi will form the chorionic membrane that invades the maternal decidua and represents an echogenic rind or rim that you will see in ultrasound surrounding a sonolucent center, that what we refer to as a gestational sac by transvaginal ultrasound. And by the way, gestational sac is not an anatomic structure, and I will tell you why. So HCG, when can we detect HCG for the first time by urine test? It is between 30 and 50 milli-international units. That is when you can detect it by any of the available urinary assay. What is the minimum rise that we should see in 48 hours to call a pregnancy is a healthy pregnancy or possibly intrauterine pregnancy? There is a wide variation in the range. People propose 53, people propose lower, people propose higher. We'll examine the evidence and tell you what we currently use here. You have to remember that 15 to 20% of ectopic pregnancy would have a normal doubling time of HCG, and these are the ectopics that have a fetus with a fetal heart. So when do we see pregnancy by ultrasound? At what HCG level? It's around 1,000. And that is very much, we used to use the word discriminatory zone in the past. That's very much the modern discriminatory zone, if I may say so. So all of us are familiar with this graph from the textbooks about the rise of HCG that peaks around 10 to 12 weeks and then start dropping around 20 weeks gestation. It plateaus until the end. And that is coincidental with the rise of estrogen and progesterone in preparation for labor. That is from the academic perspective, but that's not the curve that we use clinically when we deal with patients. So what we need to use here is knowing what is the minimum rise in HCG in an ultimately viable pregnancy that we could see in 48 hours. Is it 66%? Is it 53%? Is it 35%? Or it depends. So the first paper that, like the holy book in early pregnancy, came from Duke University almost 40 years ago. And that is the one that said, you should see 66% rise in 48 hours. Otherwise, you would have a suspicion about the viability of that pregnancy. You'd be surprised to know that this paper was based only in 20 patients and it used transabdominal ultrasound, as well as it represents only 85% of the confidence limit, not the 95 or 99 percentile. So definitely lacks sensitivity and specificity. Another one came from Penn State University, from Kurt Bernhardt, who's an authority in the field of pregnancy. He said that the minimum rise could be 53%, and that was based on studying close to 800 patients with pain and bleeding whose initial ultrasound was not diagnostic, but ended up to have a viable pregnancy at the end. So the average increase is more than double in his series. The minimum increase that he reported to have a viable pregnancy is around 53%, and that is where the 53% came from. He reported also the greatest increase to be up to more than threefolds, more than tripling of the beta-HCG at the 0 point. Again, that study looked into symptomatic patients, so this may not apply to normal pregnancy and patients who are asymptomatic. CPER in fertility sterility also proposed 35% based on his symptomatic cohort of 1,000 patients. But this was limited by the fact that they missed 17% of ectopic pregnancy and doesn't apply to multiples, and it's only applicable for symptomatic pregnancies. So what do we use currently and why? So you have to be careful when you calculate the rise of the beta-HCG. So the beta-HCG or the HCG rise differs according to the baseline level. So the expected minimum rise at 48 hours for a viable intrauterine pregnancy depends on your initial beta-HCG. If your initial beta-HCG is less than 1,500, then a 49% or more obviously would be adequate to say that this pregnancy is going to be most likely a viable intrauterine pregnancy. If your baseline is 1,500 to 3,000, then 40% would be enough, actually. If your baseline is more than 3,000, then even less than 35%, 33% has been shown in many publications that it is adequate for a viable pregnancy. So to summarize this portion, what is the exact value of HCG assay? So you have to remember that a single HCG not reliable to determine neither the location to differentiate between intrauterine pregnancy and ectopic, nor the viability to differentiate between viable and non-viable pregnancy. You have to have serial assays in order to do that. What it tells you that you have a biochemical pregnancy somewhere, and if that pregnancy was lost at this stage, meaning that the patient started to bleed and then her urine pregnancy test becomes negative, then you're dealing with what we call as a biochemical pregnancy, or also a PBL. One thing I wanted you to take home is that once you see a gestational sac in the uterus, there is no value of HCG assays. You have to stop measuring HCG assays. They are not going to change your clinical management once the sac is seen inside the uterus. So let's go to the next stage here in our talk, ultrasound. So one of the earliest studies, beautiful study that looked into that actually was by Stephen Goldstein from New York State University. He's an authority in the field as well. So what he did, he looked into more than 200 women seeking elective termination of a healthy pregnancy. And HCG was measured when a gestational sac was less than 1 centimeter. And he found the following. He found that all normal gestation has a sac visualized when the sac is 4 millimeter or more. And also he was able to see a gestation sac inside the uterus when the HCG is more than 1,025, provided that the uterus is normal with a homogeneous echo pattern, antiverted or retroverted, but not axial. And that's one of the limitations of transvaginal scans that I'll share with you shortly. So once you do an ultrasound and you have a positive HCG, and if the ultrasound is showing that you do not have an intrauterine pregnancy or you do not have an ectopic pregnancy, then you're dealing with a different clinical entity. That is pregnancy of unknown location. And this pregnancy of unknown location will either resolve, and that will be called resolved pregnancy of unknown location, or persist, and that is persistent pregnancy of unknown location that needs to be managed. If it evolves into ectopic pregnancy or intrauterine pregnancy, that's another story. So I'm going to spend some time talking about pregnancy of unknown location later, because that's one of the epidemics that resulted from the improvements of the technology and HCG assay as well as ultrasound. So if you lose a pregnancy at this stage before seeing anything by ultrasound, you're dealing with either a biochemical pregnancy or pregnancy of unknown location. And that is, both of them are called the non-visualized pregnancy losses. You have to remember that there are challenges to the visibility of early pregnancy, depending on the type of the frequency and the magnification of the equipment that you're using, the obesity or the BMI of the patient. Axial uterus is the most challenging one to scan during early pregnancies. And if there is any coexisting pathology, particularly fibroids, adenomyosis, and multiple gestations. So what would be the first ultrasound sign that you would see in a pregnancy, even before seeing a gestational sac? The echogenic pattern of the deciduary action in the uterus. And you see that between an HCG level of 30 to 1,000. And that is a gap during which you cannot see a gestational sac. CBER also looked into this to see if it has any prognostic value when you measure the endometrial thickness to tell your patient, that is your patient coming, she has a positive pregnancy test, and you measure the endometrial thickness here. What can you tell her from this? You can't tell her that much. You can tell her that endometrial thickness is not a reliable predictor of outcome. But there is something for you as a clinician to know that if the endometrial thickness is less than 6 millimeter, it's very unlikely for this pregnancy to be a viable intrauterine pregnancy. Mostly, it's an early loss of some sort. So people use different terminology to present that, endometrial echo, thickness, and stripe. I don't think stripe is an accurate terminology to use. So if you're going to use one, particularly for publications and academic reasons, use echo or thickness. Excuse me. Gestational sac. So we agreed that we can start to see it according to the magnitude of your machine when the HCG is more than 1,000. You have to remember that gestational sac is a sonographic terminology. It's not an anatomy. There is nothing anatomically called the gestational sac, and I'll show you that in a second in more details. It appears, as you can see here, is an echogenic rind of chorionic membrane invading the maternal decidua around a sonolucent hypoechoic plaque-like center. It is the first definitive sign of a pregnancy, and it could be seen as early as 4 weeks plus few days in areas with certain machines, and it grows 1 millimeter a day. So this is one of the early scans they just did a couple of weeks ago, actually. So this is a gestational sac. You can see a yolk sac, also the beginning of a yolk sac appearing here, and the HCG of that patient was around 1,300. So the second structure that you start seeing is a yolk sac. So it is the first structure to be visualized within the so-called gestational sac. It is round and bright rim, as you can see here, and it should be less than 6 millimeter. It's a very poor prognostic sign to see an enlarged yolk sac more than 7 millimeter, solid yolk sac that's like a solid blotch of white stuff, or duplicated yolk sac. Mostly that is a doomed pregnancy destined to end with an early embryonic demise. So this is one of our patients that we saw actually. She has a yolk sac that measures 10 millimeter. You put the Doppler, which you shouldn't use frequently. I'll tell you why shortly. No fetal heart on the embryonic pole. This patient ended up to be trisomy 16 when we send the products of conception for embryo genetics. So location, location, location. So pregnancy can kill people sometimes if it's in the wrong position. So this is a patient, again, I saw a couple of weeks ago. You see the hyperechogenic area here. Beta HCG was rising appropriately. This is a deciduary action. There is no gestational sac inside. And here's the right ovary. Next to the right ovary, there is something that's not so clear to me. So we went and we put the Doppler flow around it. It's obviously separate from the ovary, and the Doppler color doesn't go around, it feeds into it. And on a bigger magnification, you could see what seems to be the beginning of a gestational sac within that mass that's next to the ovary. And that was an ectopic pregnancy that was treated with methotrexate. I want you to compare this case to this one. This is again an early gestational sac inside the uterus. And on the right ovary, I found this cystic structure that looked suspicious too. So basically, simple step to do here is to plot the color flow. And then when you see the classic ring of fire around, you're dealing with a normal corpus luteum. So this is most likely, I'm yet to see her again. So this is most likely going to be a healthy intrauterine pregnancy. And so just to take a quick message here, I want you to compare and contrast an ectopic pregnancy with the flow going directly, separate from the ovary, to a structure that's cystic within the ovary with a ring of fire. That is the difference between abnormal and normal. Again, this is a 4mm embryo. You could appreciate a fetal heart in the beginning of, and the yolk sac next to it within the chorionic cavity. There is a famous sign that we read all the time in the textbooks called diamond ring sign that you can see between 4 to 6 weeks. This is a 5 weeks and 6 day ultrasound, embryo and yolk sac given the classical diamond ring appearance. So this is a visualized pregnancy, whether it's with a yolk sac, a gestational sac or chorionic cavity, gestational sac and a yolk sac, gestational sac and embryo at different levels. When you see something inside the uterus, you're dealing with a visualized pregnancy. And if you lose it at this stage, it could be different from when you lose it in the preclinical stage. So this is called visualized pregnancy or clinical pregnancy. So let's look in more details into the anatomy and why I keep saying that gestational sac is not an atomic term. So here's an early pregnancy. You see an embryo here. You see amniotic membrane here with the amniotic cavity, yolk sac outside. So that is very much what represents the embryo's surroundings. And if you look into this image, here is the amniotic membrane, yolk sac, and what's outside is a chorionic cavity. So people traditionally has been referring to the entire structure as a gestational sac, where there's nothing actually within it called the gestational sac. So there's a chorionic membrane and cavity. There is a amniotic membrane and cavity within which you have the embryo. So the amount of details that we can get, let somebody like Dr. Goldstein to engrave the word sonomicroscopy. If you hold this pregnancy in your hand and you look at it by your naked eye, you would not be able to see anything. But if you put a high resolution ultrasound, you can appreciate how much details you can see. This is a 6 weeks and 2 days ultrasound. Then the important next point here, besides seeing something, is to confirm that it is viable. So then you have to look into cardiac activity. So in any ultimately normal pregnancy, usually it had a cardiac activity before you can see it. So how do we evaluate it? And what is the prognostic value when you see a beating heart in an embryo? So traditionally and long time ago, people used to use a spectral bar so the patient can hear the boom, boom, boom sound for the heart. So everybody's happy in the room, mom is happy, physician is happy, and the father is happy, but the embryo is not happy actually, and I'll tell you why. And also sometimes you put the color flow in the heart so you can see the colors coming. So I want to ask you to stop doing that in your practice, and I'll tell you why, and I'll tell you what you should use moving forwards. So before I tell you this is not a wrong slide. It's intended to be there. Ultrasound can cut tissue and destroy organs. This is a harmonic scalpel that I'm using for a laparoscopic myomectomy, and that is based on ultrasound technology. So you see ultrasound cutting the entire myometrium and dissecting the myoma out of the uterus, and you can see the amount of heating and bubbling that's coming around. So it's not really absolutely safe that we feel the liberty to use any amount and any source of ultrasound during early pregnancy. So what should we use? We should use EMMO to monitor cardiac activity. The mother does not need to hear it because it is dangerous to the embryo particularly in early pregnancy. And that actually led the SOGC, Society of Obstetricians and Gynecologists of Canada, to put a whole guideline together about obstetric ultrasound and its biological effects and safety. They said clearly that ultrasound exposure should be as low as reasonably achievable. They're using the acronym ALARA for that, because of the potential for tissue heating when the thermal index exceeds 1. And they went on to further recommend that spectral power and color Doppler should be avoided while imaging the fetus in the first trimester, except in those circumstances where their use contributes to the investigation of the pregnancy at high risk of trisomy or anomalies. So when should you use them? When you are suspicious about viability, when you are suspicious about anomalies. So now you did your early scan. What can you tell your patient about her risk of loss according to what you see? If you see a gestational sac, the risk of loss according to this study is around 12%. You see a yolk sac, the risk decreases to 8%. If you see an embryo, if it is less than 5, the risk is 7, 6 to 10, 3%, and if it's more than 10, the risk is less than 1%. So that is mostly applicable to a normal and infertile asymptomatic young women. So if you see a fetal heart on top of what you saw before, then the risk of miscarriage drops, or the risk of fetal embryonic demise fall from 15% to around 3%. But that does not apply to women with recurrent pregnancy loss. The likelihood of failure of this pregnancy and loss of this pregnancy would remain the same, around 15 to 25%. And that prognostic value is also maternal age dependent. So the risk is less than 5% in those who are 35 or younger, 10% in those between 36 and 39, and 29% for women above the age of 40, even if you see a fetal heart. So you are doing your scan. What should be the ideal scan like? What should you include in your scan in order to say that this is a good quality scan? I do not need to scan this patient again. Or what should represent a suboptimal quality scan, excuse me, which should make you think about repeating the scan in a better place. So actually, the SOGC also put some guidelines for us. So for the first trimester up to 14 weeks, your scan should include the presence or absence of yolk sac, the fetal number. If multiple, you have to put the karyotype and the amnioticity, the location of the gestational sac, because in the epidemic era of cesarean section, we diagnose a lot of cesarean sections, ectopics, and also pregnancies that are near the angle of the uterus, cornual ectopics, I mean. Cardiac activity, presence or absence, and the fetal heart rate, the crown rump length, and the maternal pelvic anatomy is an integral part of the assessment. Because guess what? You can diagnose heterotopic pregnancies even if you see a gestational sac inside. So if you're not looking, you can miss it easily, and that can lead to serious consequences. Yes, it is rare, but in the era of assisted reproduction, it's probably slightly commoner than what it used to be before. If your fetus is more than 11 weeks, you have to add the head circumference, the bilateral diameter, the choroid plexus, making sure that it's filling the ventricles, stomach bubble, and the symmetrical lung fields that you can see. I'll show you some of these scans. The presence of 4 limbs with 3 segments is unexcusable to miss after 11 weeks, because diagnose a lot of issues that could happen in those pregnancies. Also can have a look at the abdominal wall cord insertion. Then the issue of nuchal translucency, you have to be certified to measure that. Actually, I'm not certified to measure nuchal translucency. It should be measured in millimeters to 1 decimal point, and it has to be measured between when the embryo is measuring 45 to 84 millimeters, i.e. 11 weeks and beyond. So what is the story about the 7 to 10 weeks anomaly screen? Can you screen for congenital anomalies that early during pregnancy? Well, the answer is probably not at this stage, but you can highly suspect it, with a relatively good degree of accuracy. So during the 7 to 10 week scan, you can scan the entire body, the cranial end, the spine and the limbs, the neck and the face, the heart, the chest, the abdominal wall, the genitourinary system, the umbilical cord insertion, and the amniotic membrane. So this is a 7 weeks and 3 days embryo inside the uterus. This is a slightly bigger one at 9 weeks and 0 days. This is 10 weeks and 1 day. The measurement here is 10 and 5 because it's growing above the 50th percentile. So the dates here would not change from your dating scan. This is based on the dating scan, not based on the measurement that you're seeing in front of you. Nasal bone you can see, and the nasal bone cartilage starts to classify and ossify between 8 to 9 weeks actually, and absence of nasal bone calcification is seen in up to 70% of Down syndrome. So you don't need an NIPT test to suspect if you can't see the nasal bone, then you can probably think about doing further testing. 10 weeks and 1 day, you can see the 3 segments of a lower limb here, the femur, the leg, and the foot. So if one of them is missing, you're dealing with something here that you have to investigate further. You do not need to wait until 20 weeks to confirm that diagnosis. And here, the choroid plexus filling the ventricle, giving the beautiful butterfly appearance in the same embryo with the midline falx serpi that you can see in the fetal head. Any deviation here, you can diagnose acrania or the anencephaly, or highly suspect. Can diagnose if you are proficient in ultrasound, whole prosencephaly, and cephalocele. If there's something bulging here that's black and cystic structure, you should suspect encephalocele in these cases. And once you see them, you would never forget them. Again, I just want to put this all together in one small video clip to you. This is a scan. You see the embryo here with a fetal heart. It is within the amniotic membrane, not within the chorionic membrane. And you see the egg sac here. What if you don't see an amniotic membrane? That's a very poor prognostic sign, actually. It is premature rupture of membranes in the first trimester. But the patient wouldn't recognize it because guess what? It's not rupturing to the outside. It's rupturing into the chorionic cavity, as you can see here. So this is a gloomy prognosis if you don't see an amniotic membrane, even if you see a fetal heart. If that is confirmed, this embryo will most likely die. Here is a 10 weeks and 1 day. You could see the head. You could see the beating for chamber heart. You could see equal sides of the chest. You could see the spine of the baby as well. You could see the cranial end that is bigger than the rump end. And if that is smaller than the rump end, if the cranial end is smaller than the rump end, you should highly suspect major cranial anomaly, acrania, or anencephaly. That is, you don't need to wait beyond 10, 11 weeks to diagnose. So this is 11 and 3. This is 11 and 6. This is 12 weeks and 0 days. You see the cranial end here. You see the spine. You see the bubble in the bladder of this baby here. So you know what's normal from my previous images and the part that we just discussed. If you get if you get used to normal, you can highly suspect at least abnormal. Can highly suspect cranial end errors or problems, including anencephaly, spinal limbs like phacomelia, neck and face, increased nuchal thickness, that is highly suspicious for Down syndrome or early hydropic changes. Cardiac exostrophy of the heart is completely outside the chest, which starts that way, but later on in the embryonic as well as the fetal, it becomes within the cavity of the chest. Abdominal wall abnormalities like gastroschisis and omphalocele, genitourinary system, umbilical cord abnormalities, amniotic membrane. Just seeing an amniotic membrane is a good prognostic sign. If you don't see it, it's a bad prognostic sign. I'm not intending to talk about the anomalies that you can see, but I'll show you some of the examples that I just picked. You see here the mid-gut hernia that doesn't seem to be physiological. So this patient needs to be further evaluated later. That is 10 weeks and 6 days. And you see here the increased nuchal thickness here of this pregnancy at 11 weeks and 5 days. And by the way, the cystic hygroma or increased nuchal thickness can be transient. So you can see it between 11 and 13 weeks. And when you scan later beyond that, it may disappear in certain Down syndrome cases. So that's something you have to put in account. So that's why you have to stick to measure it between the 45 and 84 coronary length millimeter in size. What is the limitation of the early anomaly scan? Few centers are offering it based on expertise, but we need more development and external validation before advertising and using it for the public. But you can suspect it at 10, 11 weeks. And then in this case, you have to validate it further later on during the fetal life between 12 and 15 weeks or so. It helps to avoid unnecessary cell-free DNA testing. We have an epidemic of NIPT test here. All women wants to do it. I'm not sure if it's available in in Egypt and other countries in the Middle East or not. But if you really see all of these anomalies, or you see extremely thick local translucency or more than 3 millimeter, you don't really need to do this because this is a screening test. It's not going to diagnose things for you. Probably you should counsel the patient about going to the diagnostic test like amniocentesis right away. So that is this part. Next part is early pregnancy failure. How can we diagnose early pregnancy failure and how can we manage it? So at the end of your first trimester scan, you should be able to categorize pregnancy into one of 5 categories. 1 and 5 are unequivocal. Everybody should know. 1 is a definite ectopic pregnancy, which you see an extrauterine gestational sac with a yolk sac plus minus an embryo, like the case I've shown you. 5 is also should be unmistakable. It's an intrauterine pregnancy or IUP. You see a sac plus minus a sac with a yolk sac plus minus an embryo plus minus a fetal heart. If the gestational sac is more than 25 millimeter, that is also an intrauterine pregnancy, even without a yolk sac and without an embryo. The other categories are probable ectopic, when you have an adnexal mass or extrauterine sac-like structure with or without free fluid, highly suspicious for ectopic. That's number 2. Number 4 is a probable intrauterine pregnancy when you see an intrauterine sac-like structure without a yolk sac, without an embryo. The one in the middle is the one that we're going to talk about shortly, which is a pregnancy of unknown location. You have a positive HCG or a high-level HCG, irrespective of the rise. You do an ultrasound, you don't see anything inside or outside the uterus. That is a pregnancy of unknown location. So viability is life and death. It's very critical. So that's what pushed New England Journal of Medicine to put an international consensus panel to assess early pregnancy failure. When can we unequivocally and conclusively say that this embryo is dead? There are 5 criteria that were put together by this panel. If you have a sac more than 25 millimeter with no embryo, no yolk sac, that is a dead early pregnancy. If you have a coronary blens more than 7 millimeter with no cardiac activity, that is a time where you should see a cardiac activity. That's again an early pregnancy demise. If you see a coronary blens that's less than 7 millimeter, no fetal heart, on 2 ultrasounds, at least 7 days apart, that's again a dead one. Any empty gestational sac without yolk sac or embryo on 2 ultrasounds, at least 1 week apart. And any gestational sac with a yolk sac, no embryo, on 2 ultrasound occasions 10 days apart. These are the 5 criteria, each one of which is enough to diagnose early embryonic failure or early embryonic demise. There are some uncertainties when it comes to scanning. So that is what pregnancy of uncertain viability is. So these are pregnancies that are suspicious but not diagnostic for a failed pregnancy. If you have an absence of an embryo 6 weeks past the last menstrual period, if the dates are reliable, if you have an empty amnion, there is an amnion, but there is no embryo in it, adjacent to the yolk sac. If you have an enlarged yolk sac more than 7 millimeter, mostly that is a doomed pregnancy as well. If you have a small gestational sac relative to the embryonic size, which means the difference between the size of the sac and the size of the embryo is less than 5 millimeter, that's mostly going to be a suspicious, uncertain pregnancy of uncertain viability. What do? Just repeat the scan later, and that should give you the answer. So what's our protocol for confirmed early embryonic demise and why? So we scan the patient if the gestational sac is more than 25 millimeter. Look for a yolk sac. If you see a yolk sac, that's enough to say that this is an early embryonic demise and move on. If you see a sac, look for a crown rump length. If you did not see a crown rump length, again, this is a demise. If you see a crown rump length, measure the size. If the size is more than 10 millimeter with a positive cardiac activity, you can confirm two things here. First, it's a live intrauterine pregnancy, and you can use this scan for dating. If it is 10 millimeter or more, you cannot use an ultrasound scan to date the pregnancy if it is less than 10 millimeter size, the crown rump length. At least that's our protocol. If you don't see a fetal heart more than 10 millimeter, again, this is a demise. If it is less than 7 millimeter and you see a positive fetal cardiac activity, then a live intrauterine pregnancy can be diagnosed, but you cannot use it for dating. So the patient has to come again for dating within 10 to 14 days. If you do not see a fetal heart, this is a pregnancy of uncertain viability, rescan in 7 to 10 days. And if you see a change, like it grows from 7 becomes 10, or you see a fetal heart, that is a viable intrauterine pregnancy. If you don't see a change, then you are dealing with an early embryonic demise. Again, how about between 7 and 9? Very much you look at the fetal heart, negative demise, positive life. If the gestational sac is less than 25 millimeter, you see a yolk sac, then you see a crown rump length. You don't see a crown rump length, this pregnancy of uncertain viability, rescan in 11 days. And if you see a change, this is viable. You don't see a change, this is an early embryonic demise. If the gestational sac is less than 25, you see a yolk sac, you don't see a yolk sac, this is still considered pregnancy of unknown location because that sac inside the uterus can be a pseudo sac. And those patients we rescan in 14 days. How do we manage? Just want to spend a few minutes here because it's important and I'll tell you why. So just as roughly you can code this to your patient. If the patient was an early embryonic demise, wait for up to two weeks. The expected management will be successful in 60 to 80% of the time. If you use medical management, either misoprostol or the MIFI-MISO protocol, if you have mifepristone available in your center, success is between roughly 80 to 90%. The surgical is 97%, but the surgical one has lots of problems, and I'll show you some of them, So first, if you're gonna use surgical, I advocate and I strongly ask you to start using vacuum aspiration, which is a better choice in achieving complete uterine evacuation and preventing routine products of conception and Asherman syndrome compared to the blind sharp curettage alone. I think that's a practice that we have to revisit because it has a lot of side effects, as we will share. So that is the New England Journal of Medicine that presented the misoprostol protocol that showed that it is highly effective. Simply give the patient mifepristone, and then 24 hours later, they receive 800 micrograms of misoprostol. And the results of this RCT was confirmed in another one that was published in Lancet last year. So in this study of close to 2,000 patients that looked into the risk of intrauterine adhesions after first trimester loss, they found that the risk could be up to 20%. And DNC appeared to be the major driver behind intrauterine adhesions, with the number of losses also a contributing factor and a prognostic factor. The more the losses, the more likelihood of intrauterine pregnancy. So again, I want to call on avoiding sharp curettage and terminating a demised early embryonic pregnancy. And the reason behind that is this. This is a beautiful endometrium, non-pregnant, you can see it. This is the most resilient mucosa in the human body. The strongest mucosa in the human body is endometrium in the non-pregnant state of the uterus. That is the only mucosa that sheds every month completely and then regenerates altogether. But when the pregnancy happens with the decidual changes, it becomes the most vulnerable. mucosa of the human body, very liable for damage. And when you go to do DNC here, you should not expect the gritty sensation. Gritty sensation means that you are scratching the myometrium. You are done with the entire decidua and you are destroying part of the myometrium. And if you send this to pathology, you will see myometrial cells inside the histology report. And that is, again, you have to stay vigilant. Those patients are more likely to develop Asherman syndrome. So I've seen an epidemic of Asherman syndrome lately, and that led us to develop, for patients with retained products of conception after vacuum aspiration, to develop a protocol for selective hysteroscopic removal of retained products of conception. You see my short device here. These are the retained products of conception. This is the rest of the decidua. You are targeting the chorionic villi only, and you are trying to shave them cleanly without doing any damage to the rest of the endometrial cavity to prevent the risk of adhesion. Those patients are vulnerable for infection. This is another patient who have much more retained products of conception inside the uterus. And again, using the selective removal with the MyoSure device. What would you do if you don't have that device? In resistant cases, in the experienced hand, you can use the regular hysteroscope, but without any energy, zero energy. You can shave it with the blunt, non-connected to energy probe, actually, or loop. Anyway, so what causes early embryonic demise? Just gonna skip this slide for the sake of time. So that's one of the historical article. That's the most elegant, actually, that started all of that discussion. They looked into 144 spontaneous miscarriages. They got the chorionic villi, examined them with karyotype, and they found that 70% have abnormal chromosomes, of which autosomal trisomies were the commonest. So roughly, you can tell any patient who have an early embryonic demise before 10 weeks, 70% of the time, this is actually secondary to the fact that this embryo is chromosomally abnormal. So that's what I tell most patients, actually. I tell them, thanks God this pregnancy ended, because remember, early pregnancy loss is a devastating news to the parents, particularly if it is recurrent. But if you have a confirmation, you say, well, this pregnancy is destined to die anyway. And if it continued, it will have ended up with a fetal demise or an intrauterine fetal death or delivery of a baby with major congenital anomalies. So Allah subhanahu wa ta'ala, just for the sake that you clear this uterus early, and you get to be ready for the next pregnancy. This pregnancy is ended early, so you can go and move on to attempt pregnancy rather than wasting 9 more months of this pregnancy and ending also with nothing. So that's important. So why do pregnancies end up with chromosomal abnormalities? It depends on the stage of development. If the error happens at the time of gametogenesis, whether it's oogenesis or spermatogenesis, you're going to deal with autosomal trisomies. If it happens during fertilization, you deal with triploidies from dispermy mostly. If it happens during the first cell division or division of the zygote, then you're dealing with tetraploidy or mosaicisms. So these abnormalities are not expected to be recurrent or repetitive. They are mostly sporadic, except one exception. If the parents are carrier of structure chromosomal rearrangements, like translocations, whether it is reciprocal or Robertsonian, or inversion, which is a common type. So that is the 70%. What are the other 30%? Everything else you investigate for. So when you investigate a patient with recurrent pregnancy loss, you are investigating mostly for 30% of the causes if you don't have the genetic testing in hand for the products of conception. And that everything you want: anatomy, endocrinology, genetics, infectious, autoimmune, idiopathic. And that would be expected to be repeated or repetitive or recurrent. That's why you have to address the cause and treat it. And that is not the topic of today's talk. So this is some of our data looking into the aneuploidy in patients with recurrent pregnancy loss according to the maternal age. You could see the linear, almost trinary relationship. The older they are, the more likely to have aneuploidy. And also the majority of those pregnancies end between 5 and 10 weeks, rarely beyond 10 weeks. So it's usually an early embryonic demise. And if you look into the different types, trisomies are the commonest. And all chromosomes are involved, as you could see in this graph. The common ones are 13, 16, 21, and 22. So I kept referring to pregnancy of unknown location a lot. What is it? What is pregnancy of unknown location as a clinical entity, and how can we manage it? So it is a woman with a positive HCG who goes for an ultrasound, and there's no confirmation of intrauterine or extrauterine pregnancy. You make no assumption of HCG, so irrespective of the HCG level. You make no assumptions about symptoms, so irrespective of bleeding and pain. And that is pregnancy of unknown location. But you have to remember, this is not a final diagnosis. You have to end up categorizing pregnancy of unknown location into one of 4 categories, as I will show you in a second. So it is the result of the widening gap between the biochemical detection, which is 30 to 50, and the ultrasound detection, which is 1,000. So usually the beta HCG is between 50 and 1,000, and you see nothing in the ultrasound. That is pregnancy of unknown location. Approximately 10% of those pregnancies are ectopic. So the risk of ectopic is really high. So that's why those patients has to be followed carefully according to a written protocol. And I'll share with you our protocol in a second. Studies have shown that it is very safe to monitor. So you can monitor even if there is a 10% risk of ectopic, and you should not treat for ectopic until the suspicion is really high. The risk of rupture is 2 to 3 in 1,000 with the PUL, if not appropriately treated. So if the HCG ends up rising appropriately, you are likely dealing with a healthy intrauterine pregnancy. If the HCG is rising abnormally, then the risk of having ectopic is high. And if HCG level has dropped by 15%, and I'll tell you why the 15% here in a second, it is most likely that an early pregnancy has stopped growing, be it an ectopic or be it intrauterine. It may resolve on its own if we continue to see further decline of the HCG. So that is a category where a close follow-up will be necessary. So what is the outcome? What are the expected outcome? The first is, most desirable one is intrauterine pregnancy, where you start seeing a sac plus minus an embryo. Or the most dreaded outcome is ectopic pregnancy. You will see a gestational sac, like we said earlier. That is a category that you have to treat either medically or surgically. The two in between, you are dealing with either a failing pregnancy of unknown location, where the HCG is falling, then you need no treatment. Or you're dealing with what I referred to earlier, persistent pregnancy of unknown location, where the HCG is not falling, and that is a category that you can treat with methotrexate after appropriate counseling, even if you do not see a sac or a mass in the adnexa that can refer to an ectopic pregnancy. So red and green. So these two are very much green. They were supposed to be green. Sorry for not changing the color. These are the red ones that you are supposed to treat with mostly methotrexate for the persistent PUL, and methotrexate or surgery according to this clinical scenario if it is an ectopic pregnancy. So where this 15% came from? It came from this elegant study, actually, that looked into close to 400 patients with pregnancy of unknown location. They used 189 to train the system that they developed, and then 200 patients as a test. What they did is very simple. They divided the HCG level at 48 hours by the HCG level at 0. So they measured 2 assays. The first one is a 0, and the second one is 48 hours later. They divide the two. They found that the optimal HCG ratio of 0.87 to detect a low-risk PUL, which most likely end up with being an intrauterine pregnancy. In our center, for the sake of simplicity, so 0.87, which is 87%, minus 100% is 13. For the sake of simplicity, we are using 15 as a cutoff limit. So explain it further. So what is HCG ratio for protection of low-risk PUL? It's defined as the optimal HCG ratio for protection of failing. So if you make that calculation, it is 15% or more, you're dealing with a failing PUL that does not need intervention most of the time. So if you're using this cutoff, you can safely adopt a non-intervention approach in women with pregnancy of unknown location. This protocol applies only to stable, minimally symptomatic patients when the PET HCG is between 25 and 3,500. Ultrasound findings consistent with the ultrasound classification 2, 3, 4 that I referred to earlier, which are probable intrauterine, pregnancy of unknown location, and probable ectopic. Pregnancy is desired and patient is agreeable to ongoing monitoring. So let's make it simple. You diagnose PUL based on initial HCG in an outside lab or your lab. You repeated it 48 hours later. You did the calculations. The HCG ratio is more than 85%. You are going to repeat the PET HCG in 48 hours again. And then you're gonna book the patient for another ultrasound for dating. Mostly this is going to be a viable pregnancy if you did not see an ectopic. If it is less than 0.8, this is mostly a failing PUL. All you need to do is ask the patient to do a home pregnancy test in 3 weeks. If it is negative, she's done. This pregnancy is cleared. If it is positive, she comes back for further assessment to rule out ectopic. To sum up, pregnancy can end in the preclinical phase, and that's the non-visualized loss, or once you start to see it, and these are the visualized pregnancy losses, as you can see here. So non-visualized and visualized. Few words about that. So the majority of pregnancies from this pregnancy pyramid end before clinical recognition. And that includes the 2 categories I mentioned, the biochemical pregnancy and pregnancy of unknown location. And both of those represent close to 60% of pregnancy losses. Above that line are the visualized losses, visualized pregnancies, which are the 10% miscarriages that happen and the 30% live birth rate. So if you start with 100, 30% of your pregnancy are lost before implantation, 30 after, 10 miscarriages after recognition, and the rest will end up with live birth. Is it prognostically important from the live birth perspective or likelihoods to suspect and diagnose non-visualized pregnancy? There was an elegant study that looked into that actually, and they looked into close to 500 patients with recurrent pregnancy loss with more than one subsequent pregnancy. They found that the relative risk for having a live birth with non-visualized pregnancy loss is the same, like if the previous miscarriages were visualized. And hence they proposed including that in the assessment according to the protocol you're using for patients with recurrent pregnancy loss. And that what led to the change in the terminology by the Assay. I encourage everyone to read these two-page documents. It's open access, available. Tells you what kind of pregnancy are you dealing with. Just dealing with biochemical reserved pregnancy of unknown location according to the criteria we discussed, or treated persistent pregnancy of unknown location with methotrexate, as we mentioned early. And once visualized, you're either dealing with an embryonic or yolk sac miscarriage or embryonic. That is all before 10 weeks embryonic age. Anything beyond 10 weeks, you're dealing with fetal miscarriage, and that is different. And I want to stress that because if the size of the embryo is more than 10 week size, you don't need to wait for 2 miscarriages to investigate. This is a late loss, and that is enough even for antiphospholipid antibody screen. We tried to replicate that study in our center. Actually, we found that we have, out of all patients, 1,000 patients referred to the recurrent pregnancy loss clinic, 14% of them were purely non-visualized losses, either biochemicals or pregnancy of unknown location. And around 26 have visualized losses, and the rest, 60%, were mixture. They have the same causes, except anatomical causes are more common in visualized losses, which is to be expected. I'm just coming to my summary slides, and I'm very sorry for being long. Oh boy, spoke for 1 hour. So today we discussed what constitutes an early pregnancy, how to diagnose it, and how to accurately implement HCG assays and early ultrasound. We talked about pregnancy of uncertain viability and how can we change this uncertainty to certainty. We talked about early embryonic demise. We talked about pregnancy of unknown location and the protocols for both and the management, and my call to stop using sharp karyotype. And we talked about the non-visualized pregnancy loss and the fact that you have to watch for, because it is prognostically important. We also talked about biochemical pregnancy is a diagnosis based on an HCG of 30 to 50, given the available assay kits in the market. We talked about ultrasound detection, which is usually when you have more than 1,000 milli international units HCG. We also addressed the early anatomy scan and its role in current clinical practice between 7 to 10 weeks. And again, my second call for the safe use of ultrasound and avoiding the use of color Doppler and the use of the power. We also talked about our local protocols for pregnancy of uncertain viability, early pregnancy demise, pregnancy of unknown location, and the rising interest in non-visualized pregnancy losses and their clinical and prognostic importance. And thank you very much for your attention, and I'm happy to answer any questions. You can type your questions in the chat, and the team, Dr. Tarek or Dr. Mohamed, will be helping us with the question. And before I end, I want to remind you with the upcoming talk on March 7th by Jonah Havelock from our center. He will be talking about the new developments in the field of neuroendocrinology and the mechanism of hormone action. He's an IVF specialist. He does purely IVF. He doesn't do anything else, but he has a great knowledge in this area, and he can marry the two and interest the core endocrinology, basic reproductive biology stuff with the clinical stuff. So stay tuned for March 7th at the same time through the same platform, and I thank you again for your attention. Okay.
Thank you very much, Professor Bedaiwy, for this very elegant presentation. Myself, and I think most of the audience, I'd like to tell you that we have nearly 500 attendees from all over the world, mainly from Egypt, and we have more than 250 international registrants. So if we can start the questions, if you don't mind.
Of course.
You mentioned what's known as the diamond ring sign. Should I search for it in every pregnancy?
No, you don't. Sorry to cut you short. You don't. This is a finding. What you should search for is the criteria that I mentioned, and the ideal high quality early scan, which includes the crown rump length, the amniotic sac, the yolk sac, and of course the chorionic sac outside, in addition to the maternal organs, particularly the rest of the uterus for multiples, and the adnexa to rule out ectopic.
Okay. The second question is what the Doppler and the B mode, because there is a lot of, as you mentioned, people who would like to make the patient, her partner, and the whole family happy by allowing them to hear the fetal heart. Are there any detected anomalies which can be attributed to using such intervention or such scanning, especially if it is a very short? I don't think that anyone would do this for a minute even. It might be for less than 15 to 30 seconds.
Well, let me, before the literature and before the evidence, I can tell you what we do in our practice. I have been in North America in close to 20 years now, as you know, between the US and Canada. I haven't seen it done in any early pregnancy, except for the fetal center, fetal diagnostic center. So it is our routine protocol to use the M mode to detect the fetal heart. So that is not out of the blue. This is based on guidelines. So I've shared with you the guidelines coming from the SOGC. I'm by no means an expert in fetal medicine, and I'm not very privy with literature, but I'm happy to share what I quoted from the Canadian guidelines with everybody. Actually, by the way, they are free and available on the internet. You can search them yourself. They clearly said you don't need to use them except in two situations. One, suspected anomalies. Two, you are suspecting aneuploidy of some sort and you are trying to get more information about either viability or the anatomy of the heart. So it is as simple as that. They did not reach to this conclusion, and we did not reach to that practice change out of the blue. Whether it is short or long, that is rationalizing to ourselves what we're doing. So I can stab somebody with a knife in his arm for 2 seconds or 2 minutes. We don't know, we don't have data. I've shown you the harmonic scalpel with definitely higher energy and what it could do. Duration of exposure, you don't know if somebody else is gonna scan this patient beyond you. I'm not trying to scare people or anything. Mostly short exposure may be okay, maybe not. You don't follow these embryos longitudinally. You don't know what happened to them later on in their pregnancy. You don't load what happens to their development. And remember, I mentioned in the beginning, this is a period of embryogenesis. Any insult is very much a whole body insult to all systems. So why we care about thalidomide or cytotoxic medications? If the patient took 1 pill of methotrexate during early pregnancy, accidentally, would you be worried? It's 1 pill, it's not 10. Would you be worried if she took something else that is proved to be teratogenic? Even swallowing it, it will gonna go through first pass effect in the liver, and it may not reach the baby in a high concentration anyway. So it's very much the same analogy if we are trying to think rationally. But if you're looking for the evidence, read the guideline, the SOGC guidelines, and I'm sure there are other guidelines from other societies. And as I said in the beginning, I'm not a fetal medicine expert. Probably people who have more experience in fetal medicine than me can comment further on that.
Third question is, are there any lab fallacies for HCG measurement?
Yes, but if the fallacies are consistent, probably they will be translated. So hence the importance, hence the lack of importance of one assay. You can make decisions based on it. And the importance of repeat assays if you are going to rely on HCG only to make a clinical decisions. So it's a good idea to go to the same lab to do the different assay rather than jumping between the lab. Because if they have an error in their machine, it will be transferred to the first assay as well as the second assay. So the answer is yes. So that's why consistency and repeat measurement sometimes is helpful depending on the clinical scenarios.
The next question is the 7th to the 10th week anomaly scan. Is it for everyone? Is it for those who are at high risk, including those who had assisted conception?
I would say it is for every physician who call himself qualified to do a first trimester scan. You're not supposed to make a diagnosis here. We are just trying to ask you to pay attention. That's it. If you don't see a 3-segment limb, you don't need to tell the patient that she has phacomelia or absent limbs. All you need to do is refer her to somebody with expertise 2 weeks later. That anomaly that you suspected could be nothing or could be something serious. If it is something serious, you'll be grateful. The patient will be grateful. You diagnose a problem early. You make the patients more ready and prepared for that. And remember, one anomaly is probably a sign for other anomalies that you cannot detect. because if you have an anomaly early on, it's likely that you find more if you look carefully and if you refer the patient to centers that are specialized. I know in Assiut you have a fetal unit, and some of the private centers also have fetal units. So it is an opportunity. You're not doing a scan to tell the patient, oh, see, look, you have a heart here. This is a viable pregnancy. You have to have minimum criteria, and these minimum criteria are standardized. This is not a part of the minimum criteria to do an anomaly scan, but it could be in the future. So it's an opportunity to look at the whole body, look at the chest and heart. And if you do them a lot, you get used to what's normal. So you would know if there's something deviating. And in this case, you refer the patient to somebody who's better expertise than yours. Like in my case, actually, this mid-gut hernia patient that I saw, I'm not qualified to do anomaly scans. I refer to the fetal center and happens to have gastroschisis. The other patient happened to be diagnosed with Down syndrome, the one with increased local translucency. That's why I intentionally did not include any advanced ultrasound scan. I'm like you, I'm a reproductive endocrinologist, basically, who has interest in early pregnancy and recurrent pregnancy loss. I didn't show you any 3D images because I'm sure in the audience there's lots of people who have expertise with that. I'm telling you what I do in day-to-day practice and when my antennas are high for anomalies, and that's why I'm referring patients to people with expertise. I think in this time and world, everybody, we are not supposed to be expert in everything. We are supposed to have a minimum requirement of clinical competencies that would allow us to decipher patients into those that we can manage ourselves and those that we have to transfer to people who have better expertise than us or to centers of excellence. Because even in your town, you may not get the answer. The patient has to go somewhere else in order to get the answer that she needs.
Okay, the next question is a bit far from the relevance of your presentation, but would you recommend anomaly scan at 20 weeks for women who had assisted conception, IVF, ICSI?
That is routine. We recommend anomaly scan for everybody between 18 and 20 weeks. That is kind of a routine practice, whether it's natural conception or it is an assisted reproduction conception.
We can, in Egypt, it might be difficult for every woman to have this, difficult and expensive to have this anomaly scan. So we would like to categorize.
All right, well, before we categorize, I want to call on you as a department head that's actually, and your colleagues, other department heads in the entire country, that this is an integral service. And if you don't have the expertise in your center to do an anatomy screen, you should train people to do anatomy screen between 8 to 14 weeks. I know that there are private centers, but I know that there are university hospitals that can make this available to people who cannot pay and go privately to an anomaly scan. I'm sure lots of our young assistant lecturers and trainees would love to develop expertise in that direction. And once they know it, they can teach other and becomes integral part of practice. So our departments and different universities, or even our colleagues in the Ministry of Health, if we compare the way we are practicing obstetrics and gynecology today, compared to the way we were practicing when I was a resident and when you were a resident, there is a huge revolution in the services that we are providing to our patients at different levels. I think this is one of the key services that should be integrated. Well, should you categorize? Yes. Now, if it is not available, I would say any woman above the age of 35, anybody with a history of recurrent pregnancy loss, anybody with IVF pregnancy once established is no different from other pregnancies. So whatever applies to, well, there are differences. We can talk about that another time. But 22 years old who got pregnant with ICSI due to severe male factor infertility is definitely a lower risk pregnancy compared to a 39 weeks old woman who conceived on her own, because you could see the difference here. And if I have one spot for anatomy scan, I would offer it to the 39 who conceived on her own. I don't think we should let money drive the way we practice, or a patient that is coming from a private sector compared to a patient coming from the public sector. Patients are patients. For providing care, we should provide the best we can in a way to be equal and neutral to everybody. And if the services are not available, we should do our best effort to make them available.
Okay. The next question, thank you very much. The next question is, can you have retained products of conception with a negative pregnancy test?
Yes, you can. And unfortunately, I have seen that a lot in my practice because I get a lot of referrals for Ashermans. Once the trophoblasts die last, remember that. So the trophoblasts die last as part of the embryo. So you can still have an early embryonic demise and you have progesterone in the circulation and HCG in the circulation for a long time. But for until a certain point, it starts to calcify and ossify and become dead trophoblast. If it is dead, it's not active anymore. It doesn't secrete HCG. So you can see retained products that mummified one way or the other or calcified, and HCG is not very high or undetectable. And that the only way you can diagnose them is high resolution transvaginal ultrasound or hysteroscopy.
Okay, the next question is, do you have in Canada specially designed or manufactured misoprostol which can be given vaginally?
Yeah, misoprostol can be given vaginally everywhere.
No, yes, but manufactured for vaginal use. Our misoprostol in Egypt, it's
for oral.
Manufactured for oral, but we use it vaginally. There has been a brand, but is now not available in Egypt, that it is manufactured for vaginal use.
Yeah, good question. I don't know, because what happens, I don't even write it. When we have a patient, we give it to the patient in the clinic. We give the mifepristone for free and the misoprostol for free for the patient. So I can look into that and see if it is designed for vaginal use only, and I come back to you about this question.
Okay. Is there any scenario or situation that you might allow pregnancy continue after methotrexate injection?
Well, tough question. Well, basically that is based on counseling. First of all, patient shouldn't have gotten methotrexate, but if it happened by accident, there is a mix in the literature about teratogenicity. So it really depends on the patient. So you counsel the patient appropriately about the risks, and you keep her under close, vigilant observation. If she elects to continue this pregnancy, if it is desired, and you make decisions according to the clinical scenario. She was exposed to methotrexate. Remember, methotrexate is not recommended to be used during pregnancy, but if it happened and used accidentally, there are reports about viable outcomes. So there are reports about anomalies. So in this case, you have to counsel and have the patient make the decision. But you should not be a surrogate decision maker for the patient and tell you must do and so and so and so. I think share the data and tell her, and she can decide.
Again and again, about the harmful effects of early use of Doppler and color Doppler. Is it evidence-based? The first thing. The second thing is, this is from Omar Sha'ban, and the second is from Mahmoud Al-Alim. Is there the high-frequency transvaginal ultrasound? Is it more harmful, or the frequency is not an effect, or doesn't have an effect?
Well, I know that I opened a can of worms by putting this slide in my talk, and I was very hesitant. Looks like I'm going to lose a lot of good friends based on this slide, but I felt really morally obliged to share it because it's in a national guideline that drives the practice in an entire country. Omar, if you're asking for the evidence, I'll send you the whole document and you can read it. And I ask you to share with us what you find. I did not examine the evidence myself. I read the guidelines, but the guidelines are not put together without a meticulous and careful look into the evidence.
Can I ask you?
I am happy to admit if I'm wrong later on, if you can prove otherwise.
No, I'd like to that if you can put it with the reading articles.
I'll email it to you.
Okay. Is there a definite rate of clearance of HCG after pregnancy failure?
Well, it depends on the lab you're using, really. So that's why we use this 15%. You don't need to bring the patient every 48 hours to pay the cost for an HCG assay. If the drop is more than 15%, this is a failing pregnancy, irrespective of where it is, whether it's inside the uterus or outside, provided that the patient is not symptomatic and provided that she's meeting the criteria that we talked about. And in this case, all she needs to do in 3 weeks is a home pregnancy test that she can do. Mostly will be negative, nothing needs to be done. If it is positive, then she has to come back to you, you do a scan and you do HCG again.
Okay. I myself have seen in one of your last slides what's known as yolk sac miscarriage.
Yes.
What is yolk sac miscarriage?
Well, it's a descriptive terminology. It means that you have an embryo there. It's in the ISHRI guidelines and in the ISHRI definition. You have a gestational sac that's comprised of amniotic membrane and yolk sac only. There is no embryo. So there is no embryo inside the amniotic membrane.
So this equals to what we used to call an embryonic pregnancy or blighted ovum.
Correct. And the word blighted ovum is no longer in use, by the way.
Blighted ovum is no longer in use.
Correct.
Okay. The other question is also from Professor Mahmoud Ali. Egyptian ladies sometimes fear from transvaginal ultrasound in early pregnancy.
I think they have the right to do so.
Okay.
Transvaginal, you just with appropriate counseling, and you told them that this is not going to be harmful. Yeah, you are right on the uterus. You are in close proximity. So whatever is coming from the probe is hitting the pregnancy firsthand. Just counsel them. This is not something that we're going to use routinely. It's used with the lowest amount. It's not to be scared. It is safe to be used if it is used appropriately. People use it all over the world, so they can use it when it's indicated to diagnose early pregnancy problems.
One said that, is there any possibility of doing a DNC rather than methotrexate for pregnancy of unknown location?
Well, no, because misoprostol and mifeprostol and DNC are meant to terminate an early embryonic intrauterine demise, not extrauterine. There is, remember, with a pregnancy of unknown location, there is a protocol actually where people sample the lining. I can pull you the article and send it to you and see if there is a chorionic villi inside. They can do manual vacuum aspiration of those pregnancy of unknown location. I didn't want to go into the details of this, not to confuse people, but it's not studied. I'm not sure it will be successful. That's as much as I know right now.
Okay. Again, between the 11th and 13th first trimester anomaly scan, can we include Doppler again to fulfill soft markers of
in two situations: suspected anomalies, heart problems that you cannot see otherwise.
Okay.
According to the guidelines that were written by people who have way, way, way more experience than me.
Another question saying that, don't you think that hysteroscopic evacuation or evacuation under stroke guidance is a bit over? I'm sorry for the question.
No, I really admire whoever asked this question, and I absolutely agree with him. It is over. It is over. That's why it should be done only in selective cases, and it should not be offered routinely. And I apologize if I was not understood correctly. These are patients, the two patients that you have seen. One of them actually failed two vacuum aspirations. and probably 30 or 40 days after the confirmation of the early embryonic demise. These are very, very, very selected patients. So these are patients who would otherwise be subjected to the third or the fourth D&C to evacuate, or the first manual evacuation too. So on the contrary, really, I'm respectful for this question and to the person who asked it. It is over, shouldn't be used routinely. It is to be used in tertiary care facilities for people who fail first, second, and third line, particularly those. And by the way, these two patients have a history of Asherman syndrome before too, that I personally corrected, and they have retained products after. So these are vulnerable uteruses, vulnerable patients who is in a suboptimal situation, and hysteroscopic targeted removal is only for those patients.
In accordance or in the same line, would you recommend the vacuum aspiration under ultrasound guidance? Because someone asked if I shouldn't expert or I get the gritty sensation during the NC. How can I know that there are no more remnants?
You don't need to know. Remember, the uterus is a good structure. It knows very well how to take good care of itself most of the time. It expels miscarriages on its own. Before the myoprostol and DNC, our mothers and grandmothers were miscarrying without problems for a lot of years and centuries. It expels products of menstruation every month. And the majority of the time, 90% success was expected, 80% success was expected in management within 2 weeks. If you extend the observation period to a month, it would be even more. You have the medical means of terminating this pregnancy. If you have retained products, deal with it later. If you cannot resist the temptation to use a curette, then use a blunt one. You don't need to use a sharp one. There are blunt curettes that you can use if you don't have. You can do ultrasound guided removal if you think that you left something inside. But gritty is myometrium. That's what I am trying to communicate. The endometrium is velvety. يعني بالعربي زي القطيفة كده، معلش يعني. Have you ever felt a gritty sensation when you have a velvety structure or a velvety cloth? If you're feeling gritty, you are down to the myometrium. That's it. You should know that. I know that's the way we used to learn as a young resident, but that has to change. And if she has retained products, believe me, most of the time, she will take care of it on her own without any consequences, most of the time. The fact that we're talking about extremes here and exception does not mean that they are the norm. They happen because complications you can die from a shot. You can give you like a penicillin shot and you have anaphylaxis and you die. But what is the likelihood here? Same for retained products of conception.
I think now we come to an end. We have some more questions, but you have already answered them during your lecture. Because yes, we have a lot of questions about University of British Columbia protocol, algorithm, and guidelines. So yes.
We don't have guidelines. Guidelines are to come from institutions that are higher than us, but we have protocols. Yes. Once I get the appropriate permission from the local, I don't think they would have any problems with that. I'm happy to share.
Okay, another question for ectopic, would you give a single shot or pregnancy one, or would you give a single shot of methotrexate, or would you give 3, or would you give 5?
What depends. There are very well-established protocols. I encourage the person who asked this question to look into the SRM guidelines. It's available, it's free, it's on the internet. This talk is not about ectopic, and I'm happy about to talk about ectopic another day. There are protocols. There are indications for a single use methotrexate. There are indications for the multi-dose protocol. Typically multi-dose we use a lot actually for advanced pregnancies, for cesarean section scar ectopic pregnancies, for Cornwall pregnancies, because we diagnose quite a bit of those, and we're a tertiary care facility. So it depends. There is the methotrexate only multiple dose protocol and the methotrexate leucovorin that's similar to the one used for the management of gestational trophoblastic disease. So pick one and stick with it, but most importantly, have a clear protocol and know exactly what to do and what to look for. Day 0, day 4, day 7, HCG scanning, HCG assays, and then deciding whether you need a second dose based on the drop or otherwise.
The last question, I'm sorry for keeping you.
No, I have more time than what I thought. So as many questions as you want.
Which is better, to use a cytogenic study for products of conception or parent karyotyping for balanced translocation?
We are talking about two different things here. So paternal karyotype is testing the parents. So that tells the parents if they are carrier of structural chromosomal rearrangements or not. The risk of which is between 3 to 5%. The commonest three are Robertsonian, reciprocal, and inversions. And they are transmissible. They are associated with high risk miscarriage. And by the way, if you take them and do IVF on them, I have some experience with that, they tend to be low responders, and they tend to produce less embryos, actually, compared to their age-matched controls. That is one entity. So that is telling the parent you have such and such. That may give you a likelihood of roughly 50% affected or 50% healthy, 25% carrier, and 25% affected offsprings that will end up with a miscarriage. Testing the products of conception, with or without testing the parents, is going to look into two genetic entities here, not one. So the parents, you're taking into one genetic problem, which is a structural rearrangements, which is within the chromosome. So there is a piece of one chromosome that translocates somewhere else. So numerically, those patients are 46XX for the mother and 46XY for the father. But from within that, there is a segment of the chromosome that is translocated or inverted. When you talk about the embryogenetics of the products of conception, you're looking into two things. We're looking into the numerical problems, which is the commonest, that you cannot test the parents for, which are sporadic. And they happen, as I said, either during gametogenesis, fertilization, or during the first cleavage of the embryo. And these are all types of aneuploidies that can affect any chromosome from chromosome 1 to 22 and X and Y. That is what you test for. So you can test either without the other. But if you find like a structured chromosomal rearrangement in the products of conception, then you have to go back. If the parents were not tested, you have to test them. And that's one of the protocols that are used for investigations, patients with recurrent pregnancy loss, to see where it's that coming from and the size of the translocation, the complexity, and whether those patients will be candidate for BGT-SR, which is pre-implantation genetic testing for structural rearrangements, whether with or without aneuploidy or not.
Thank you very much, Professor Bedaiwy. Thank you all for attending this excellent presentation and excellent webinar. And can you please, Mohamed, re-announce for the next webinar?
Happy to, and that is coming here. I think I can share screen again.
Yes, it is.
Sure, right there. It's already there. So this is about new developments in the field of neuroendocrinology and mechanism of hormone action, what the IVF specialist should know. And that's Dr. John Havelock from Associate Professor at the University of British Columbia. He's also the co-director of a series of IVF practices in West Canada, in Vancouver, Victoria, and Edmonton. So please join me to welcome John on the 7th. We'll have some open forum like today, a lecture to be followed with adequate time for questions.
Thank you very much.
Thank you. Thank you, Professor Tarek.
Thank you all. And we wish you a very good night. Hope this was beneficial. It was beneficial for myself. And I'm going to revisit the website and check the lecture again and hear it at peace, at more peace than I am now. And I advise all participants to look at the lecture or the presentation at the link of the next webinar, and you are going to put a Facebook link that you can go directly and have a look at this presentation and the other presentations, the coming presentations after being forecasted. Thank you a lot and wish you all a very good night.